Okay, so we don't want to start.
You can start.
Okay, so today's presentation or indeed discussion is on a topic known as postpartum hemorrhage. Postpartum hemorrhage is one of those very important topics that every clinician and midwife that works within labor ward, postnatal ward, or indeed maternity wing in general needs to know. Why is it an important topic? It is an important topic because a woman, just like a man, will only contain 5 liters of blood. 5 liters is a very small volume. And secondly, in terms of the rate of loss of blood, I've argued with my colleagues that you cannot compare the bleeding from a woman who has just delivered in the context of PPH with the kind of bleeding that you find in general surgery, be it from a ruptured spleen or from a femur fracture, for instance. You can't compare. And that tells you that postpartum hemorrhage is a time-dependent emergency. Just like cord prolapse, just like fetal distress, just like shoulder distortion. Time is of essence. Indeed, just like HIE or birth asphyxia as we used to call it. Because you might do the right steps, the right processes, but you have already lost time. The outcome will not be desirable. Clear? Now, we go back to talking about postpartum hemorrhage. So let's look a bit at the definition. Again, no need to write notes. Notes are there. Everything that I was saying is in my notes. I've just opened the folder in my brain. So, postpartum hemorrhage, let's start with definition. Postpartum hemorrhage has got 2 definitions. So the first definition, we were calling it a traditional definition. And it's falling out of favor because it lacks objectivity. Whereas the newer definition is known as a functional definition, which is now more acceptable because it gives more of a safe and more objective parameter. So what do I mean? So previously we all know that postpartum hemorrhage traditionally then was defined as excessive vaginal bleeding following delivery of more than 500 mils, that is after a vaginal delivery, or more than 1,000 mils following a cesarean delivery. Now, the problem with that definition is that no one has a measuring cylinder to see that mom, you have only bled up to 350 mils. You are waiting for 150 mils. That's academic indiscipline. How can you do that? Okay? Neither do we have that objectivity because in most cases, estimated blood loss is underestimated. So that subjectivity is not good because you might end up missing out on timely management of an emergency. So we've moved towards the functional definition where we are saying excessive vaginal bleeding following delivery that causes or in brackets has potential to cause hemodynamic instability. So there are no numbers attached. So what this means is that hemodynamic instability is a situation where either there are symptoms and signs of anemia or there are signs of hypovolemic shock. You get the point? So a patient could have bled 50 mils in your opinion, but then they tell you to say, doctor, I feel blackout, dizzy, weak, headache, palpitations, fainting. Those are symptoms of anemia. Or indeed, they bled 50 mils in your opinion, based on your assessment, yet patient is paper white in terms of conjunctival pallor. Patient has got a hemic murmur and is tachycardic. I mean, those are signs of anemia. So, notwithstanding what you think has been lost, because don't forget, pre-existing anemia could actually tip easily into PPH. Because you'll be seeing a normal blood loss, yet patient had an HbO of 5 because of several causes of anemia in pregnancy. So that qualifies. Anything that takes us towards the direction of anemia qualifies to be PPH. The other aspect of hemodynamic instability is signs of hypovolemic shock, which we all know. Pulse shoots above 110, weak threading, BP drops to less than 90/60, there is reduced urine output, patient becomes restless, cool clammy extremities, and everything we know that goes with hypovolemic shock. Again, that qualifies to be PPH. Now, we do not need to wait for anemia. Neither should we wait for shock. But if a midwife looks at how much the blood is coming out vaginally following delivery, even before these systems decompensate to lead to anemia or shock, they have to call for help. That is why in my definition I've put in brackets has potential to cause. Okay? So that we are on the side of safety. Clear? Any questions on that? I think we are clear on the definition. Now, let me quickly go to the famous 4 Ts of PPH, which are the causes of postpartum hemorrhage. We know that these 4 Ts will remain as our standard. We have tone, we have trauma, tissue, thrombin. Tone, trauma, tissue, thrombin. These 4 Ts refer to the causes of postpartum hemorrhage. Now, what are these Ts? When it comes to tone, we are defining tone as basically uterine atony, right? It's a misnomer. We are saying tone, but basically we are referring to failure of tone. So that's atony. So what does atony mean? It means that it's the failure or delay of the uterus to contract following delivery. Because when a baby comes out, the uterus is supposed to squeeze and close on itself. But imagine it's doing that at a very slow rate, or it's just failing to do that. Now, what are the risk factors to uterine atony? We know. Number 1, it's high parity. For instance, grand mount parity. Para 8, para 9, 10, so on. Number 2, we are referring to causes of uterine overdistension. The uterus was just too overballooned. Why should the uterus become overballooned? We are talking about multiple pregnancy. We are talking about macrosomia, which is a big baby, polyhydramnios. These will cause the uterus to overdistend and it will take, obviously, long for it to contract. Also, don't forget uterine fibroids, because what happens is that where the fibroid is, it takes out most of the normal myometria. Whereas the adjacent sides where there is no fibroid, the myometrium is normal. So what will be happening is that the uterus will be contracting in an uncoordinated manner. One side contracts, the other side doesn't contract it. And ultimately, it will lead to atony completely. The other one is what we just discussed in the last lecture, which was antepartum hemorrhage. Because both placental previa and placenta abruption will cause uterine atony. Because in the previa, the placenta has taken up most of the lower segments. So there is no myometrium. Mind you, the lower segment is naturally thin, and most of it has been taken by the placenta, which will eventually come out. So there will be atony in the lower uterine segment. For abruption, I think I did explain the seepage of blood in the myometrium and the Covolea's picture and everything else that is to atony. Finally, do not forget a full bladder. A full urinary bladder is dangerous because the bladder is anterior-inferior to the uterus, because the uterus is mostly anteverted and anteflexed. So the uterus will be like this and the bladder is sitting here. Most of you have done cesarean sections, you know where the bladder is. Now imagine the bladder is distended. It means that this uterus will fail to contract because there's something intervening between it, and therefore there will be atony. So those are some of the causes of uterine atony. Let's go to trauma. Now, for trauma, what are we saying? Trauma, we are saying it refers to injury to the genital tract. So from above downwards, we are talking about the uterus, the cervix, and the vagina, including the perineum. So anything can be injured along that way. So let's start from the top. We are talking about uterine rupture. And I will not belabor on uterine rupture because it appeared under antepartum hemorrhage. We talked about risk factors to uterine rupture such as high parity again. We talked about previous uterine operations such as myomectomy, classic cesarean section, repeated lower segment cesarean section. We did talk about conioectopic, we talked about previous uterine repair, and so on and so forth, including hysterectomy. Then we did mention something to do with the use of oxytocics and prostaglandins for either induction or augmentation of labor. So misoprostol, dinoprost, oxytocin itself can lead to a rupture. Remember, we talked about transverse lie in labor. And we then went further to talk about what happens in shoulder dystocia in terms of instead of using suprapubic Rubin maneuver, we end up using fundal pressure and so on and so forth. Those can rupture the uterus. What else can be the issue there? It might not always be uterine rupture, but it will be uterine dehiscence, meaning partial separation of the myometrial wall, which is like a partial rupture. So whether it's an ovate rupture or a partial rupture, it doesn't matter, but we know that those are the risk factors. What about injury to the cervix, vagina, perineum? Imagine somebody has just delivered and the 4th degree vaginal tear, cervix is cut in all directions. What could come to your mind? Like, what could have caused this? So the first thing is poor management of second stage. Why am I saying poor management of second stage? We all know that when you are managing labor, particularly the second stage, what are you supposed to do? You stabilize the perineum with pad and flex the oncoming fetal head. That's what we do. Imagine we don't do that. The baby will find its way out. And the baby's way of finding its path might be very detrimental. The second thing is use of episiotomy when you need to. So an experienced midwife will know that I think the vaginal introitus is too small. This head is big. When this baby props up, it will cause serious injuries. So they will do an episiotomy, mediolateral episiotomy, so that the extension is directed in a certain direction, rather than the baby creating its own area of weakness. It's similar to cesarean section. You've seen what we do at cesarean section? When you make an incision on the uterus, make a small smile, then you extend it in a smiley direction. Why? Because you want a situation where should there be extension, let the extension go superolaterally and not go purely laterally to hit into the uterus. So that is like you are directing a problem, which will be easier for you to manage. That's the principle behind the episiotomy. So some of these, no wonder I was mentioning, say, how come it's always Dr. Mulenga delivering a baby, he always has a 4th degree tear. Dr. Mulenga delivers him, there's no tear. You have to ask yourself, well, how is my technique? How come me I always have cervical tears? How come I always have vaginal tears? So it speaks to your anticipation of the problem at second stage. The other thing is macrosomia. Obviously, a big baby will cause injury. The other one is malpresentation. Remember, we talked about breech. If you don't do the maneuvers properly, you can do more harm than good. And there will be genital tract injuries, including the use of instruments, obstetric forceps, and indeed vacuum. If you don't know how to use these instruments, don't even use them. Probably just take the patient for cesarean section, because this is a procedure. The way we consider a cesarean section as a procedure, that's how even use of instruments is. It's also a procedure. So it has the prerequisites. It has got certain things that are required to be done for you to do it safely and in a correct manner. Away from trauma, we can go to tissue. Tissue refers to retained products of conception. So it could be placental tissue, it could be membranes or both. Now, why should somebody end up with certain things remaining? Again, poor management of what? Third stage of labor. We know that when it comes to management of third stage of labor, there's spontaneous and there is the active management. And we always go for active management and not the passive one where the placenta comes out on its own. And we know that was a common medical school exam question. So I will not talk about it. Not so Dr. James Mulenga, my former student. I can't ask you, we should even be upset. You can ask me management of third stage, active management. But remember we said give oxytocin within a minute of delivery, all those, and the story started. But remember, when you are managing third stage of labor, what do? We are waiting for a contraction. So you can put your hand on the abdomen, wait for the contraction to come, or you can even rub a bit so that you bring the contraction a bit earlier. Expedite it, but that's optional. Then what happens? Obviously, when the contraction comes, then you apply sustained traction on the umbilical cord. Not so. Initially, I've seen, I don't want to mention names, I've seen doctors delivering at Caesar like this. Just one. Especially if it's vaginal, we follow the curve of carers. Okay? Sustained. But as you are doing that, you are applying suprapubic pressure or counter traction. Why are we doing that? To prevent the situation of uterine invasion. Not so. Now, that is also called the Branditz-Andrews maneuver, if I remember some books. And then, as the placenta is about to come, because you would have already put a kidney dish against the maternal perineum for EBL estimation, you twist the membranes so that there is complete separation. So these simple principles at third stage, if they are not followed, membranes will remain. And you know how upset the uterus is if you leave something there. Don't also forget placental accreta. Don't forget preterm labor. Why is it that when you have an inevitable abortion in a gyne ward, you almost always need to follow it up with MVA? Yet, at TEM, I've never seen anyone going for MVA after delivering a baby at TEM. So you see that if placenta at TEM easily comes out, the placenta which is not yet at TEM easily gets stuck. And that is why preterm labor can be a risk. Thrombin, I won't talk much about, it's basically coagulopathies. So that ranges from HELP syndrome to idiopathic thrombocytopenic papilla to thrombotic thrombocytopenic papilla, all the way to von Willebrand's disease and all those conditions of low platelet or disorders of clotting factors. So basically, that's what I wanted to say. Now, in conclusion, we need to look at types of postpartum hemorrhage. It can be primary or secondary. So if bleeding happens within 24 hours of delivery, it's called primary PPH. Why is it important to know about primary PPH? It's because the commonest cause of primary postpartum hemorrhage is uterine atony. I've argued with most of you before. No, we had a PPH secondary to a cervical tear. EBL 700 mils. I'll be shocked. 700 mils from a cervical tear. Or from a vaginal tear. No matter how bad the tear is, it could be a 4th degree tear where the uterus, the vagina is facing the rectum. But still, you cannot have bleeding to that extent. So the commonest cause is uterine atony at primary PPH. Second, primary PPH carries a better prognosis. Why? It's because patient is most likely within the hospital. However, secondary PPH means bleeding or PPH occurs after 24 hours, but up to maybe 6 weeks. That is more dangerous because patient would have gone home. Meaning they were previously okay, even given discharge slip, birth record. They even take a long journey to Isoka. Only to start bleeding profusely 48 or 72 hours later. And almost always they'll come in shock or others unfortunately would have demised because of the inherent challenges at transport, at being referred and being referred, something that we need to stop. If somebody needs help, at the first point of contact, everything should be done. I think that's what we should be getting to. And not refer this to this one. Imagine, Dr. Mulilo refers to Dr. Mshiki refers to Dr. Chisi refers to Dr. Simko. Do you think the complication is waiting? It's not so. So I'm talking about the dangers of secondary PPH. And what is the cause of secondary PPH? Tissue. Retained products of conception, which usually have become secondarily infected. So that's the importance of this classification. It talks to prognosis. It also talks to possible cause. So that in your mind, you need to think, what should I concentrate mostly on as I manage the patient? In conclusion now, we go to management of postpartum hemorrhage. Because PPH is such an emergency that there is nothing like no differential diagnosis, what complications, no. Let's just go to how do we manage PPH. So I'll be now a bit slow, but all the notes are there. So the first thing that we need to do is we have to call for help. Now, the call for help, like I mentioned in shoulder dystocia, implies 3 things. A shout, diagnosis, location. A shout, diagnosis, and location. What do I mean? You need to have a big voice. Me, I used to be very quiet before I became a medical student. But I was told if you don't speak, you will lose, you actually fail your exams. So you have to speak loudly, and that's how we started shouting. So, PPH, help, room, I'm going to say room because I'm so used to ETH. Okay, let's say, we can say, PPH, labor ward, help, PPH labor ward, help, or help, PPH labor ward, someone. Why am I saying that? It's because you can't just call for help. Help! People want to know whether it's you who has fallen down. Okay? And then you don't tell the people the location. They just say, that voice sounds like Dr. Mnambias. But where is he? Is he in theater or what? So, it's very important to give people a location. You call for help and you mention the diagnosis is very important. Dr. Tamara, somebody can just say, no, Dr. Mulenga is calling you. I mean, you are doing something. Is it important? Let me maybe finish what I'm doing. Then I'll go and attend to the one who's calling me. So it's very important. Something simple as that, if it's not properly handled, the response time will be very slow. Number 2, a big group of people come, like the way you are here. What should we do? You have to constitute a team and identify the team leader. Colleagues, very important. Some of you are experts at back training. I'm sure I was not part of the training, but I should think there must be team leadership. You can't manage a cardiac arrest and everyone is in picture mode, no sound. No one is saying anything. This one is doing CPR, this one is giving adrenaline, this one is doing rhythm check, this one is for the defibrillator in the hand. You can't do that. There must be somebody who is just watching and giving instructions. So it's similar. So we'll say, okay, thank you very much, Dr. Lani, Dr. Zulu, you'll be this side, Dr. Mwango and Sumkoko, you'll be this side, GC and William will be this side. There must be some kind of a team. You might not need everyone, because when there's too much congestion, there will be confusion. Number 2, you also need to have a team leader. So a best team leader is one who, if you are 2 doctors, for instance, one can just step aside and become the team leader. Because a best team leader is one who is not involved in the resuscitation, but is just watching, like in the terraces of Anfield. You know where Anfield is? Okay? Now, after doing that, what are we supposed to do? We go to the patient. So the team leader will have to explain to the patient briefly the situation. Mommy, congratulations, you've delivered, but you are bleeding and it's an emergency. We want you to be fine so that you can go and breastfeed your baby. So kindly cooperate and relax. Okay? If you don't talk to the client will become apprehensive. Imagine the way you are seated, this one is pulling the leg, this one is hitting patient will almost resist, and you will take it as a form of being uncooperative, which is unfair to the patient. The second thing is that after we have explained the situation and asked the patient to cooperate and relax, the next thing that we are supposed to do is ensure a sterile field. Colleagues, this is extremely important. You can stop the bleeding, you pursue bleeding to its rightful end and you stop it, but you have introduced infection. The patient will come back 2 weeks later, profusely pouring pus, and we know the fate of that patient. Okay, so I would always think we need to upgrade our standards. Not, of course, this is a very nice hospital, but let's give standards across all the health facilities that are giving deliveries. Let's just do the right things. If somebody is about to deliver a baby, what are we supposed to do? We ask them, what is your preferred position? But advice for the thought on. Number 2, what are you supposed to do? You're supposed to scrub. The same way you do in theater. With a hand towel. Double glove. Not because you are scared that infection can get your way, but the gloves that you use to deliver should be removed, so that these other inner gloves are the ones that are used for newborn resuscitation. That's what I was taught. Okay? And also, don't forget that after you've put your gloves, you are supposed to swab the patient. Almost just think of what you do in theater. Then you're supposed to drape the patient. You should not deliver a mother in a baby suit. You know what the baby suit is?
Yes.
And take it to be normal. Wonderful is proud of my teacher, Dr. Mulenga. I can mention her again, with your permission.
Yes.
Miss Gracilia. I always mention her because those are some of the standards that she does not want to compromise on. Why am I mentioning that? Because if second stage is properly managed in terms of sterility, then there will be no issue at PPH. Why should you start swabbing the patient when the baby is already out? So if you did that beforehand, then it means there will be a drape underneath the maternal gluteal region or perineum. There will even be another drape on top of the patient. So that should you have a problem of bleeding, everything will be sterile. You can put a needle holder, you can put a seam speculum, everything will be. Now, if all those are not there, what will happen? Why will you put the seam speculum, Dr. Man? It will be where there was meconium, where there was rectal content. And that's why I'm saying you end up with invasive procedures and just helping infection get into the uterus, which was sterile. So I'm mentioning the importance of maintaining sterility. So if people don't have drapes, I've always argued to say I can even get those drapes of the delivery pack after I swab with the abs. No matter how much the bleeding is, I will give a few seconds to swab with Savdon, drape the patient, so that I have a sterile field. Okay, now having said that, I am discouraging you colleagues from giving sedation at the beginning of the resuscitation. That can be dangerous because you are going to get peptidine 100 milligram, diazepam 20 milligram, some of you, IV, and knock off the patient. Now, you will not know what is happening to the patient. Are they really going down? Well, Dr. Mulenga, we saw a patient just, is it 2 days ago,
Yeah,
whose GCS was dropping in record time from 13 to 11 to 6 to, I was almost arguing with the first number. But I saw with myself, by the time we got to theater, she was almost unconscious, completely going in coma. So now imagine if we gave her diazepam. We'll be thinking it's the drugs which have knocked her, yet she's going down. Yes. So if you have explained properly, most mothers would look at the bigger picture to say, I need to save my baby. I need to be a little bit strong so that they finish working on me so that I go. But in most cases, it's because we don't explain to them. Yeah. Now, away from that, what do we do now? We have to divide ourselves into 3 groups. 3 groups. So the first group will be at the head and neck. if I was the mother. Then it means the Mushpi and the Chisi will be this side. Okay? Why are they this side? This side of the body. Why? It's because they want to do 4 things. The first thing that they want to do is the secure IV access. We all know 2 large bore cannulas for 16G or 16G. Number 2, as you are cannulating, what do you normally do? Naturally, you collect samples, right? So we need to collect which samples? If you can get up to 4 samples, better. And hepatitis B is not there. As some of you like doing hepatitis B. So the first thing that we're going to do is a full blood count. The second one, grouping and cross-match. So what are we grouping and cross-matching for? Whole blood, fresh frozen plasma, platelets. You can even go up to cryoprecipitates. Okay, and that is exemplified by Pack 1, Pack 2, Pack 3, which I think I talked about some other time. Even the notes, I think those are clearly explained. That in Pack 1, it's the whole blood and the FFP. In Pack 2, it's the same Pack 1, but you add platelets. And in Pack 3, it's the same Pack 2, but you add cryoprecipitates. And all these blood products of cryo, FFP, platelets are 6 units. And then for blood, you can give me 2 to 4 units. So, because you don't have time to be writing a lot of things, you can just call blood bank. Dr. Joseph Mulenga, sir, I need Pack 3. He will know that this is what you need. Clear? Now, the next sample that you collect for is bedside clotting time. Bedside clotting time is important because of the aspect of thrombin. If blood cannot clot in a red top, then it means it's not clotting in the body. So it's a systemic coagulopathy situation. And more specifically and objectively, you needed to do a clotting profile. So you do activated partial thromboplastin time, which is APTT, and the prothrombin time. That is even more specific because those numbers can be used for the endpoint of PPH, something that most people don't realize. Have you observed that when you have a DKA, people use Kussmaul's breathing and ketonuria as the endpoint and the normalization of the random blood sugar? That is incorrect. We know that DKA should be managed by use of ABGs, right? So you need to check the anion gap, the pH, the ketonemia, and all those other parameters that you use to know that really we have moved out of these images. Now, so we've talked about full blood count, grouping and cross-match, bedside clotting time, and better still, clotting profile in a blue top. Finally, we need to consider what is called serum fibrinogen. I was talking about it even during APH to say that is the best marker for coagulopathy. So, if you find that the serum fibrinogen is dropping, then you need to feather up your blood products to not just FFP but to cryoprecipitates and the much higher ones. Remember, I mentioned that there are some other blood products which we do not have, and I don't want to be academic, like the recombinant tissue factor 7 and that's activated 7A, and as well as the prothrombin complex, which we don't usually have. Okay, so we've collected the samples. What next? We need to start fluids. Now, before we start fluids, one thing we need to do is we need to repeat oxytocin. So remember, we gave oxytocin at management of third stage, but we need to repeat it again. Get that? So oxytocin 10 intentional units IM start, repeated. Now, after you repeat the oxytocin IM, then in one cannula, why did you put 2 cannulas? In one cannula, you put oxytocin infusion. Why are you calling it an infusion? Because you mix the drug with a fluid. So you can get 20 international units of oxytocin and you put it in 500 ml of Ringer's lactate or saline, and you start running it slowly. Please have it labeled and run it slowly. like at 20 to 40 drops per minute. Whereas on the other cannula, you run the ringer's lactate fast. I'm not talking about saline, I'm talking about ringer's lactate. Why? It's because use of normal saline, because of this high chloride content, can lead to hyperchloremic metabolic acidosis. So we are now discouraging use of normal saline, especially even huge amounts of saline in resuscitating a patient in hypovolemia. Of course, the best would be Hemorrhage, especially in the case where there is anemia and you want to have a replacement to blood. So you need big, like colloids, like Hemorrhage, dextran, starch. But really, that is a patient who is still stable, and you are just trying to resuscitate to offset the decomposition. So even crystalloids will do. Now, that saline, that ringer's lactate should run fast. So if Dr. Mulenga came, you will see one fluid running slowly and labeled, and the other one is running extremely fast. Then you even know that this must be a plain fluid, this must be oxytocin infusion. Clear?
Yes.
Yes. If you run oxytocin infusion too fast, it will not work because of the kinetics and dynamics of the peptide hormone. And also don't forget that you have to deliver certain milliunits per minute. So we're not going into that academic discussion. Now, what is the final thing that these people should do? They will check the vitals and the level of para. Because if you start with a pink patient, then 20 minutes later, patient becomes paper white. It shows that you are not achieving hemostasis in good time. So it means these people will tell the team leader to say, team leader, our patient now is paper white. And that needs to help you all move a bit faster. What about the second group? The second group are the runners. Please, when there's a PPH, don't all put on gloves. Because when you all put on gloves, do you know what will happen? At the end of the resuscitation, you'll be asking yourselves, what was the first BP? What was the second pulse? No one was recording because we all were running around. So there must be some people who should just be giving cannulae, strapping, documenting on the request form. They should be calling for more help in terms of asking the second on call. Who is the second on call here? Yes, asking for the second on call. We need to call Dr. Mulenga. Can you rush here? There's a PPH. Who else should they inform? They should inform the lab. Obviously, they should also inform theater. Another thing that we miss out, because if theater doesn't know, do you know what they will do? The orthopedic surgeon will bring in an open reduction and internal fixation. They don't know that there's a PPH in the power. Then, in the middle of the operation now, I don't know whether they are putting, I don't know whether it's kernels or they are putting, I've seen them with the nama screws, even those spanners. In the middle of the operation, that's when you are coming, knocking on the door. There's a PPH. The operating table is occupied. There's only one anesthetist. The patient is under GA, for instance. How are you going to operate? So whenever a PPH starts, theater has to be aware, meaning they should prepare hysterectomy sets, they should prepare anesthetic drugs. Even if those won't be used, but those should be on standby so that we cut down on time. Clear? So those runners are very important. They are the ones documenting the vitals. They are the ones doing everything, including the drugs that are being given, they are taking note. Now, finally, colleagues, and this is where I end with my lecture, I'll talk about the role of the team leader. Where does the team leader stand? If I'm the mother, the team leader will be here on my right side, because we always examine from the right side, not so. And he or she will be with one or two other colleagues. Now, I've always mentioned that this is an algorithm. You don't need to do everything, but you do and end at a point when hemostasis is comfortably achieved. So what will these people do? The first thing that they should do is uterine massage. You massage the uterus. But don't just continue massaging until the 5 liters finishes. Give yourself even 10 seconds. You are massaging, you are checking vaginally that this patient is bleeding. What are you going to do next? Catheterize the blood. Why? did you repeat oxytocin? Why did you start oxytocin infusion? Why have you rushed to massage the uterus? And why are you catheterizing to empty the bladder? You're targeting which of the T's of the four? Tone. Because we said primary PPH, the commonest cause is the uterine atone. You know, PPH is so lethal that you don't have time to start saying, no, let me make a diagnosis of the cause. You lose the 5 liters by the time you are making what you think is a diagnosis. So you are managing and diagnosing at the same time. So you anticipate that this must be atone. No wonder we follow that. Now, after you've catheterized, patient is still bleeding. What are you going to do? You inspect the perineum and the vagina to see whether there is any tear or anything of that sort that explains the bleeding, which I doubt it will explain the bleeding. So you might find there is a huge cut extending into the rectum, but it's not bleeding. Yes, the margins are oozing, but that's not what is causing the bleeding. And unfortunately, I've seen colleagues who get a lot of cotton wool and they pack the vagina so that they can repair. You've left the problem where you packed there, and you're working on it in an inconsequential part of the body. So you need to just see. If you find that this tear is not explaining the PPH, postpone the repair. Now, after inspection, I've given you the notes, I've put arrows. No wonder we can stop at any point. Then the patient continues bleeding. What are you going to do? You are going to do what is known as manual exploration of the uterus. You need to go in with your hand in the uterus. Why are you doing that? You are going to do that for 2 reasons: to remove the retained products of conception, and number 2, to check for any uterine defects. So, at this point, that's the only procedure which is uncomfortable for the patient. If I was to put all the procedures, the pain and discomfort will be at the time your hand will be going in the vagina. But if you've got a small hand like that of Dr. Mwan, maybe the patient won't feel as much as mine. But you have to apologize. Sorry. Mkwai pato ntotiana. Don't do what these other people like doing. I won't mention, where they go 4 fingers and 1 thumb is out. Do you think these 4 can reach the fundus? It's even more uncomfortable because you are putting the clitoris in between here, and that's very uncomfortable. So you have to go in, and as you go in, similar to what you do when you are doing manual removal of the placenta, you have to make sure you grab everything because you only do it once. Then as you are coming out, you check using the posterior aspect of your hand that the uterine walls are intact. Then you come out. Clear?
Clear.
Now, if during that time of manual exploration of the uterus, you find that the uterus is ruptured, how are you going to know that the uterus is ruptured? You feel even the bowels or momentum. You can feel that there is a defect there. You have to shout, team members, posterior uterine rupture diagnosed, consent, prepare for either repair or hysterectomy. You see that? Now, when you come out, what conclusion do you make? Why did you go in easily and come out? It means the uterus is still atoning. So you need now to further compound it with further drugs at that point. So which are those further drugs? You go for misoprostol, 800 micrograms per rectostat. I don't like sublingual myself because sublingual has got, it bypasses the first, or what do you call it? The first pass effect. Remember the first pass effect? Yes. It goes directly into blood. So its side effect profile is further enhanced. So I would rather put it rectal. Yes, of course, even the rectal is similar, but you can't compare with the one under the tongue. Then misoprostol 800 micrograms per stat. What else? Tranexamic acid. Now, tranexamic acid is not a uterotonic. It doesn't help the uterus contract, but it helps offset D and C because it's an antifibrinolytic agent. The third thing is you need to give the further drugs other than misoprostol and oxytocin, like which ones, which can help the uterus contract? We have ergometry, which is contraindicated in hypertension and cardiac disease. I feel bad that this drug was withdrawn because it's more powerful than oxytocin. And then there was even a combination of ergometry and the oxytocin, which was called symptometry. And of course, your last line of uterotonic is known as carboprost, which is prostaglandin F2 alpha, which is never used in one who is asthmatic. So you need to give more drugs so that you further enhance the contraction. Once that has been done, patient continues bleeding. Dr. Wang, what are you going to do? Now it means you need to go for bimanual uterine compression or aortic compression. Why are you doing that? You're trying to do that so that you minimize the bleeding. It's not a treatment on its own, but you are cognizant of the 5 liters, which is not so much a volume. So during bimanual uterine compression, what you do is one hand goes, if you can manage to go with a fist, it's even better. You go and bypass the cervix, you go into the anterior vaginal fornix. So don't go inside the uterus, but go in the anterior vaginal fornix. Vaginal, using your right, and the left hand goes abdominally and holds the posterior aspect of the uterus so that you have the uterus squeezed in between, because the uterus is anteflexed and anteverted. So this hand fits there, this other hand fits that side, so that you would have held or squeezed the upper 2/3 of the uterus. Clear? The other option, if you don't want to do that, is to do aortic compression, which is easier, because if this is the uterus, you just put your fist above the uterus so that you create pressure over the abdominal aorta so that you stop the blood flow from the heart going towards the common iliac arteries. Now, the aortic compression is easier for somebody who is slim, like me. If I had the uterus, you can do it easily. But if somebody is a bit on the high BMI side, it's very uncomfortable because you have to go through the intestines and it will be as if you are squeezing the intestines. But for one who is quite lean, it's very easy because when you press, I've seen it in my own eyes, when you press, the bleeding stops. When you let go, bleeding starts. So it's like that. So you need to utilize either bimanual uterine compression or aortic compression. Why are you doing that? You are doing that to give you time to do 2 things. The first thing is to repeat the vitals. Basically, repeat the drills. Repeat those vitals. Has blood gone to blood bank? Have they responded? Is theater aware? That fluid has finished. Can you put another one? That one is running too fast. You get the point. And even you as a team leader, you can update your colleagues while you are doing the bimanual. On our side, we have massaged, we have catheterized, we have inspected, we have done manual expiration. Everything seems to be moving well. So here we are doing bimanual so that we prepare for, what do I prepare? Cervical assessment. Because it's as if you have an idea of what's happening at the vagina and perineum. You have an idea of what has happened in the uterus because you did manual, but you don't know what is happening in between. And that's where the cervix comes in. Clear?
Yes.
Now, how is cervical assessment done? We need certain requirements for a cervical assessment to be done. The first requirement is that we need a lithotomy table. You can't do a cervical assessment on a flat surface, because the lower seam speculum will not hold. Number 2, you need a light. A light should be behind you, a spotlight, not a phone light. Number 3, you will need instruments. So which are those instruments? You will need, I've written for you there. So there are 3 sponge holding forceps, which we call the Rampley forceps, those ones with round things. 3. Then you will need 2 seam speculums, those L-shaped speculums. Then what else do you need? You will need a needle holder, a long needle holder. It's called the long Myers needle holder, and a long toothed non-tooth dissecting forceps and the stitch scissors. Then obviously you need a suture. An absorbable suture like Vicryl, which is polyglactin 910, or indeed chromic anticut. Even a 1 or a 2 round bodied is okay. That makes it a cervical set. Now you also need an assistant, and obviously a few gauzes, sterile gauzes, and the swabs. How is the cervical assessment done? Very quickly, when you come and come this side. Very quickly, I'm almost completing for this one. Yes, so this one will be the cervix. I've never seen a cervix like this. So this is the cervix. Then you are the speculum. Do one like this, down, then get the other hand up. Have you seen what he's doing?
Yes.
Then imagine me, I'm seated. So fortunately me, I will have to sit. Him will have to stand. Then where's the light? It's behind me. So it's directing, and the patient is in the tone. So it's very easy. So what I'll do is I'll get those 2 sponge holding forceps, and then I'll grab at 12 o'clock. 2 of them, one in this hand, the other one in this hand. Then I will pull, because the cervix is elasticated. So I can even pull it. Then when I pull it, I will separate. Right? Then I will check beneath the lower, the upper, the anterior lip, and even below it. I want to be sure that this segment is intact. Okay? Then when I move from there, I will come to 1 o'clock. But in theater, or indeed as a surgeon, you don't cross your hand. So once I put this one here, I will even hold them properly now like this. Right? It's supposed to be moving with me. Right? Then I will check. Right? I go. Then from there, I will come to 6 o'clock. Again, my assistant will be making sure that he's following according to the directions in which I'm moving. Now, I might be lucky that, or not even lucky, as if it's a good thing. I might find that at 9 o'clock, there is a tear. So how will I know that there is a tear? Again, the speculum. I'll put one here and one there, right? Then I will see this V, meaning it's a cervical tear. So what I will do is I will use one hand, assuming I was left-handed now. I will use one hand to hold both. And once I hold both, I will tilt the cervix to come this way so that it comes more in my direction, right? And then, of course, the assistant would have put the speculum here. So it's all about exposure. The cervix is like this. I'll push it this side, and my assistant will give me space there. And then I have a needle holder loaded with a suture. Then I will start suturing before the V or before the apex, and I will do a continuous up to the end. Clear?
Yes.
If I can't see where this V is coming from, then it's not a cervical tear. It's a uterine rupture that has extended into the cervix. So, again, my teacher would tell me that, Mulenga, you leave these sponge holding forceps like that, so that they help with some bit of hemostasis at the margins and have the patient go with them into theater. So in theater, it's not always a hysterectomy. Somebody will open abdominally there and repair halfway, and then complete the repair vaginally. Okay. So that's about the cervical assessment and the cervical tear repair. If you are done with cervical assessment and you find it is intact, or it is whatever you find, patient continues bleeding, what they're going to do? It means you are really in trouble. Right? Patient doesn't want to stop bleeding. Then again, you repeat the bimanual or aortic in preparation for another procedure, which is known as a uterine balloon tamponade. Colleagues, UPT is the simplest thing to insert. Simplest thing to insert, yet it can be life-saving. I do remember the advent, not that I'm very old, before UPTs were really rolled out and used. We used to take a long time to manage PPH. But with the coming of UPT, what was happening is that you can insert a UPT and even do other things while you are monitoring the patient closely. So for me, I'm one of the advocates of uterine balloon tamponade. Again, we will need a drill in our labor wards to show how to insert it. It's simple. You just get a Foley's catheter, which is a 18, whichever size you have, 18F or 24 or whatever, doesn't matter the size. But what do? You get a male condom and then you open it a little bit, but not completely. Because I've seen other people open it completely, then it becomes very difficult to be sure that it's inside. So just a bit of it, and then you ask for a suture. So somebody will hold the tip, right? You've inserted the male condom there, and then you put 2 times. Don't tie too much. Just tie 1 point and at 1 point, and then you have the condom there with a bit of just little space, because this is able to distend. Then after you do that, using the same instruments you had at cervical assessment, you can put a speculum, not so. Then you get a sponge holding forceps, use it for introducing the tip of the Foley's catheter into the uterine cavity. All of it as if it has gone in. Okay, not all of it, but a bigger part of it until it stops going in. Then when you do that, what should you do next? You get a bag of normal saline, giving sets. Then that's part of the 2-way catheter which discharges urine. That's where you put the giving set. You see that? Because that other one is for inflating, not so. That's where you put it. So the type of giving set you need, there are 2 types of giving sets. There are those giving sets which are thin throughout, and there are those giving sets which have got like an orange bulb. I don't know if you've seen the one I'm talking about. So those are the better ones, because those ones are big, so they fit directly into the Foley's catheter. I wish we can have a demonstration to show. They are different, because that other one, the other type which people put there will be leaking the water around. But this other one will just fit in nicely, like that. So once you fit it, then you open that fluid. So it will be running very fast. You will be shocked now, as if there was no condom in front. So it will be going in. So what the condom will be doing is it will be distending, and it will cover the entire endometrial cavity. So you need about 500 mils of that, could be enough. But for me, I like going up to maybe 700 mils. So meaning when that finishes, I even add like 200 mils. Don't give too much fluid. If you give too much fluid, patient will start having discomfort because the uterus will be trying to contract on the balloon. So you insert, and afterwards, now when you remove the giving set, what will happen? When the water starts coming out. So you ask for a 2cc syringe, 2cc, not 5. 2cc syringe, remove the plunger, that thing which moves. That plunger is what will fit in the catheter, and then you throw away the giving set. How are you going to know that this UPT is in C? It is when the water is moving. When you gently touch the fundus, as if you are squeezing the fundus backwards, the water will stop moving. When you let go, water will be entering, showing you that it is within the uterine cavity. Yes, our teachers used to tell us that we need to first test the condom. Because what if it's a leaking condom? What will be happening is that the water will be, so it will be mixing with blood. You'll be thinking that the patient is bleeding, yet this is a balloon which is defective. Yeah, which is, of course, a quality issue there in that case. And then, how do you know that the UPT has worked? Bleeding should stop completely. That's my standard. If I feel that this UPT is worked, I should not see a drop of blood. But if you've inserted the UPT up to 500 mils and above, let's say to 700 mils, and then you palpate the fundus and a gush of blood, then that UPT has failed. Clear?
Yes.
After UBT, what is the last thing that you can consider? Patient continuous bleeding. You can now consider anti-shock garment. Have you ever seen an anti-shock garment? I hope you won't be like those students who said it's a swimming costume. And those numbers refer to the water level when you're under the sea. Please, colleagues, we need to know anti-shock garment application. Yes, others have argued to say big hospitals doesn't need anti-shock garment, but I've seen how it has saved lives because it is based on evidence. And I'm sure I again mentioned my teacher, Miss Mkomba Kesilia, and another teacher of mine, Sister Rhoda Mafumba, who worked tirelessly to recruit women and have evidence. In fact, it was even interesting during our time because we even had special types of anti-shock garments which even had the calibration, where you would actually objectively measure the blood loss. And we saw how many women were saved from the anti-shock garments. Now, finally, assuming this PPH cascade ended at any point, be it at the point of massage, catheterizing, or anything, what should you do in conclusion? You have to give keftrax on 1 gram IV. You have to now give your pethidine and probably your diazepam, so that the patient can now sleep because you have comfortably achieved hemostasis, adequate pain relief, and prevent infection by giving an IV antibiotic. And don't forget to thank the patients, thank the team, all those who came to help you, and finally acknowledge their input in your notes. So Dr. Mulambia is not writing a big handwriting, Dr. James Mulambia called for a PPH. How would Dr. Mongo feel? And Dr. Lani, who came all the way from pediatrics to come and help you. So you have to thank them, and even in the notes you shall say, done as a team, with midwives on duty, with student nurses, or with medical students, with the fellow colleagues, and everyone, because you did it as a team. Now, if the bleeding continued beyond UBT, then we give that PPH a special name. It's called Intractable PPH. Intractable. It's a stubborn PPH. And what is the solution for intractable PPH? Get consent for laparotomy. Very specific. I'm not mentioning EUA. From my experience, EUA would just be another waste of time because most PPH, 98% of it is managed in labor ward. Rushing to theater is not a solution. It's just a building, but most of it is handled there. So when you go to theater, you should be very specific why you are there. You are going to open the abdomen. When you open the abdomen, what are you trying to achieve? The first thing is trying to save the uterus, not so. So you can do what is called uterine compression sutures. And I was happy yesterday, when none of you were there. I was setting a B-linge with my colleagues there, and we demonstrated, but I even gave you a video where I demonstrated how a B-linge is inserted. So that is one option. Or B-linge, Heyman, Pleureria will be able to talk about these uterine compression sutures, including the CHO. There's what's called the CHO compression suture. So these are the various options you have, but you know that in uterine compression suture, you're just trying to squeeze the uterus from without inwards, because a UPT was from within outwards, to borrow the language of the teachers. Instead of squeezing from inside, this one we are trying to physically squeeze from outside on the theater table. If that fails, then what is the other option? It is now to get important blood vessels that supply the uterus. So we normally go for the uterine artery. If the uterine artery is not responding properly, then you go for internal iliac artery. Okay, and how do you reach the internal iliac artery? We have to consult senior surgeon Dr. Tamar Taduba, who knows how to enter into the retroperitoneal space. Because there are several structures there, and you need to know of these structures I'm seeing, which one is the internal iliac. And then you get it on this side, and you get it on the other side. That's a very powerful technique. And we are hoping once we have the surgical training or any form or even just a hysterectomy, even one case, we can just go get consent and talk to the team members in theater so that we can explore the retroperitoneal spaces, so that you just appreciate the anatomy and how some of these procedures are done. Then, if those ligations are not able to help you, what other option do you have before you even chop off the uterus? Is you have what is known as the interventional radiology options. So there is what's called IABO, which is intra-aortic balloon occlusion, or there is what's called pelvic arterial embolization. So these are to do with the interventional radiology, of which I know Dr. Simkoko will be the third interventional radiologist in Zambia. I won't mention the other two, but in fact, both of them are my good friends, because we are in the same class at some point. Now, if those options fail, the last option is the hysterectomy. Why do we normally go for subtotal and not total? It's because the cervix had dilated and effaced. So it has gone too wide, lateral to the margins of the ureters, which are coming median. So for you to chop off that uterus safely and save the ureters, you need to apply the correct surgical techniques. So if you are at subtotal, you are at a higher plane where that injury, iatrogenic injury to the ureters, cannot happen. But yet I mentioned even in some fora to say you cannot run away from a total. Because if the PPH is secondary to placenta previa, and it's the lower segment which is atonic, and not the upper segment which has contracted, removing the upper part which is normal will not help the situation. Because the descending branch of the uterine artery is still discharging. Okay, so there are techniques which we shall show. In final conclusion, allow me in 1 minute or two to mention why patients die of PPH. The first thing is the lack of coordination. No team leadership, no groups, like the one you were saying. Number two, it's mismatching of the steps or omitting certain steps. So there's a PPH, people are rushing to do a cervical assessment. There's a PPH, people are rushing to suture the vaginal tears. You have missed the point. Follow an algorithm which gives plausible solutions to the problem, because we know that atony should be the thing which should be in your head first. The third thing is that when it comes to getting to theater, there's again discoordination. So you find Dr. Mango is in theater doing I don't know, what do you call those? Maybe you are removing a thyroid. The one, it's called thyroidectomy. Okay, I don't know. I mean, I'm a midwife. Then this other one is let's say this is the one in labor ward. So do you know that if there's discoordination, if he doesn't know, are you going to predict that the people there even did the uterine massage?
No.
They did a cervical assessment? You end up saying, let's put the patient in the room so that we do an EUA. And probably by the time the patient gets to theater, somebody would have put a gauze. The patient will look a bit stable, yet they are bleeding. So when they remove the gauze, there will be a gush of blood. Sister, where is the hysterectomy set? Anesthetist, sister, give me the DDA keys. I want to go and get some prop of. Oh, where is the pancreas? Zoxa has finished. DOT. Okay? So, what is supposed to happen is that a real PPH should be escorted by the team that was managing there. One is squeezing fluids, one has got a BP machine, pulse oximeter. The other one is, under aortic compression or by manual. But obviously, you can't expose the patient. What else we've got in many theaters, one is within the bowel. But if you are moving at a distance, maybe somebody can cover you with a blanket or a tent. Because that bimanual or aortic is extremely important. You might lose the 5 liters if you let go. Then when you reach the red line of theaters, there's nothing like, let's write the notes. See, people will say, but why didn't they write the notes? There you just get a consent form. You get the point? A signed consent or a thumbprint or whoever is signing for that patient, and show the theater nurse. Mind you, by then you would have already told theater, say we've got a PP PPH. When the patient gets in theater there, it's straight on the table. Scrapped, swab, rapid sequence induction, one arm brain circulation, knife on skin. Clear? If you are going to do a hysterectomy, again, let me backtrack. You want to do a hysterectomy the way you do it on an elective day. You see what we are doing on an elective day. Taking our time, explaining, even telling each other stories. This one will be what is known as a clamp, excise but no ligation approach. What do I mean? If this is a round ligament, I'll clamp, I'll cut with a McIndoe scissors, but I will not ligate. I'll leave those instruments like that. I go the other side, do the same, not suture. Go to the infundibulopelvic ligament or the ovarian ligament, the suspensory ligament. I'll do the same, no ligate. I go to the uterine, I go to the cardinal, I get all the way up to the vaginal vault. So I'll use a lot of instruments. But my point is, I achieve hemostasis at the quickest points per time. Then after I remove the uterus, with so many clamps inside, which have been counted by the scrubness and the runnerness, then I'll start ligating from inside coming up and close. But I will not talk about the actual surgical techniques, probably in another session. So that is it about the theater. So, colleagues, basically that's what happens. After the PPH has been done, at whichever point, we need now to sit the way we are under a round table and write the notes in retrospect. So that runner person there shouldn't be writing on a cover of a glove. They should have on a nice paper with the patient's name, the time the resuscitation started, the time it ended, the drugs which are being given, the vitals at different times, and so on. And when you are doing vitals in PPH, you shout. Pulse 120, BP 60 over unrecordable, saturation 98, what and what. Not where you are doing something and you're just quiet. If oxytocin has been given, oxytocin 10 dash units, IM start repeated. You get the point? What and what commenced, and so on and so forth. So that's basically a synopsis of PPH management that I had thought of discussing with you. Please, this is not a theoretical subject, meaning we need drills. Even in airports, there is a fire alarm, yet there is no fire. Just to see the speed at which people will do things. So even us, all these emergencies in obstetrics, we need to have drills so that we can narrow down in terms of speed and timeliness of, and also accurateness of our steps. Because you might have the knowledge, but the emergency is so fast that doesn't give room for you to start remembering what you did in medical school. So let us do drills, let us improve on our speed and our coordination. I rest my case. Thank you.